So we'll start with the definition, um, types, components, and then indications of for use of removable appliances, instructions for use, then the advantages and disadvantages. So that's the format that we'll pick. So on the struggle 5, any one of you can start with the definition. Can you hear me? This is an interactive session. If people are not responding now, I have a lot of things to do with my time. Can you hear me?
I hear you, ma.
Yes, ma, I can hear you. Good afternoon, ma.
Good afternoon, everyone. Struggle 5. So can anybody just start this? I want the definition of removable appliances. I'll take one or two definitions.
Yes, removable appliances.
Ma, removable appliance.
Just indicate who wants to speak, and then I'll tell you to speak.
Okay. Good afternoon, ma. Removable
Yes,
appliances are appliances that are fixed to the teeth. That. Hello, ma.
I'm listening.
Okay, they are fixed to the teeth and can be removed by the patient.
Why do you have fixed in your definition? Somebody else.
My removable appliances are orthodontic appliances that are usually fabricated in the lab and can be fitted and removed by the patient.
Okay, that's good. Anybody else?
Okay.
One more definition. Yeah.
Removable appliances are majorly they're like orthodontic devices that the patients can insert and remove by themselves, which are majorly for simple tooth movements.
All right, that's nice. So basically, your removable appliances are orthodontic appliances. So you have to make sure you include orthodontic in your definition. They are orthodontic appliances that can be fitted in and removed by the patient. And then who was the last speaker?
That's me, ma'am.
All right. So as she said, they are used for simple orthodontic tooth movement. They do not treat a wide range of malocclusions. So they're only used to treat simple malocclusions, and you don't need an orthodontist to be able to use a removable appliance. So a removable appliance is fabricated in such a way that anybody, a general dentist, can make use of the appliance. Exactly.
Yes,
Yes,
thank
Okay, so now let's move on to types. Gideon, types. Gideon. So Gideon is not in this class, eh? He just logged in. He's not here.
I'm in the class. I'm in the class.
All right. Types. What do you think?
So it could be active or passive.
Very good.
Yes, ma'am.
Expansion.
Ma, should I continue?
Yeah, I said expansion. Go ahead.
Okay, so the active ones are the ones that produce tooth movements using like active components in the appliance. While the passive ones, they don't actually cause movement. They're mostly for like space maintenance.
Okay. So to expatiate, the active appliances, as I rightly said, are appliances that have the full components of the removable appliance, and they have an active component. So they are used to produce movements, to produce simple tipping movements in the mouth, while the passive appliances do not exert any force. They are simply designed to keep the teeth in whatever particular position they are at the moment, so they do not exert any forces. So most of your retainers fall under this group, even though whoever is going to teach you guys retainers, we do have retainers that can be made active, but for the most purpose, like for the most of the time, the retainers are actually passive. So the other example of passive removal appliances are, as I said, the space maintainers. So components of a removal appliance. You guys have heard this one a lot in the clinic. So Esther, just list the 4 components and I'll pick anyone to go through each of them. Esther is not in the class though. Mama, you remember what we discussed, right?
Yes, ma. The 4 components are first component, retentive component, anchorage, and the base plate.
Very
Good
good.
afternoon, ma. There are two Esters. So I'm not sure the one that you are calling now. There are two
Okay,
Esters.
call them. Oluwa, what's your surname? Oluwa Ferami, right? That's you.
Yes,
Take us on the first component. So it's either called force or active component. Take us on that.
so they include springs and springs. They are used to they are basically the
No,
active
no,
parts of
no.
the
Esther,
component.
hold on. Esther, hold on. You're teaching. You're passing on information. So we're going to be very organized because the information you're giving, I want it to be reproducible. I want to be able to ask anyone and they can say what you said. So you can't go in like that. So there are basically like 4 components, right? Or 4 examples under that first component. So you just tell me what they are.
So the active component,
Mm-hmm.
there are four components of a removable appliance, like Denison said. The active
Mm-hmm.
component, the retentive component, the anchorage, and the base plate. The active component is used to generate necessary force that is
Mm-hmm.
required to move the teeth. And examples are springs. The springs
Good.
could be finger springs,
No,
teeth
no.
springs.
List the examples for me. Springs.
Okay, springs, labia bowls,
No.
expansion springs.
Oh, yeah, hold on. So as she said, the active components are the components of the removable appliance that produces the force, that provides the force in that appliance. And then they can be gotten from any of these 4 that I'm saying, even though one has been discontinued, it's no longer actively used. So the 4 examples are springs, bows, screws, and elastics. Are we getting that?
Yes, ma'am.
So I said springs,
Yes.
bows, screws, and elastics. So which one do you think is no longer frequently used?
Springs.
Anybody? Sorry, no, the elastics. The
Okay.
elastics. So now, Esther, you can go ahead and talk about only the springs. Somebody else will continue. Esther, talk about the springs. Continue. Or somebody
Okay.
else wants to take over.
So the springs are, like you said, component of removable orthodontic appliances. They are mainly fabricated using stainless steel wire, mainly 0.5 millimeter or 0.6 millimeter. And they're
So
usually
let me
incorporated.
pause you. Let me pause you. Like I said, we're passing information, right? So the springs is not just you can't just say stainless steel wire. You have to you have to be specific. So it's made from hard stainless steel wire. Hmm? Are you listening? All of you listening? Because these are small points. Hmm?
Yes,
It's
ma'am.
from hard stainless steel wire. And these wires contain 18% nickel and 8% chromium. These are MCQ questions and short answer questions. Hard stainless steel wire comprised of 18% nickel and 8% chromium. Noted.
Yes, ma'am.
Esther, carry on.
Okay. So, um, like you said, stainless steel wire composed of nickel and chromium, and it's
Esther,
usually
Esther, hard stainless steel wire. Put in your head now. Hard stainless steel wire. Quantify your stainless steel wire that is hard.
okay.
Good.
Hard stainless steel wire made from nickel and chromium, and it's usually incorporated into a helix to increase the wire's length, allowing for lighter and more consistent force to bring to activate the components basically. So there are different types of spring design, and the different types is based on the desired direction of movement. There is the finger spring, also known as the single cantilever spring. There is the Z spring or the double cantilever spring, and there is the T spring. There's also the cupping spring and the canine retractor. So the finger spring, like I said, is also known as the single cantilever spring. It is used mainly for mesiodistal movement, for moving a tooth along the arc, and usually protected by a guide wire to prevent accidental distortion. So this spring is used to achieve mesiodistal movement of the tooth along a arc, and is protected using a guide wire. Then there is the Z spring, also known as the double cantilever spring. It is used for labial movement to move the tooth labially forward. Maybe it can also be used for one or more teeth. It's usually used in correcting anterior crossbite because in anterior crossbite, the teeth is usually posterior, like more posterior than it should be. So their aim is to move the teeth forward labially. So use a Z spring or a double cantilever spring. Then there's the T spring. This T spring is used for buccal movement of premolars or canines. It is T-shaped and it is allowed to push a tip outwards towards the tip. Then we also have the cupping spring. It is heavy. It is omega shaped spring. It's about 1.25 millimeters. And it is used in the mid palatal region for arc expansion. It is used when maybe the arc is too small and there's overcrowding and you are trying to expand the arc to allow the tip to be set. That's what you use for. That's what you use cupping spring for. To use to widen a constricted upper jaw. Then we have the canine retractor. The canine retractor is a specialized spring. It can be buccal, it can be palatal, that is used to distalize a canine tooth after space has been created. So distalize is basically you moving the teeth back, moving the canine teeth back after you have created space for that tooth. Now that's all I have on springs now.
Esther has done very well. Oh. She has taken it like in how the 600 level will take movable appliances. Do you guys know all these things that she said?
Not all, mama.
Okay. So you ask her for her material, but she's very correct. So I'll go back to what you're supposed to know at this point, and then the questions that you most likely be asked, right? So for the first thing that we ask, like when you're calculating force and everything, there's this formula that I think Prof likes asking. There's factors affect the force applied to your spring. So there's this formula that your force is directly proportional to deflection and the radius all over the length. So those are also inside your short answer questions and your MCQs. That the force application that your spring can give you, the force is directly proportional to deflection. That's D. So the formula is just F is proportional to dr4 over L. So F is your force, D is your deflection, R is your radius. So radius raised to the power of 4 divided by length of the wire raised to the power of 3. So have you gotten that?
Yes, yes, ma'am.
Let me talk about what Esther said. So she just gave you the types of springs that you can use, you can incorporate. So you have a number. Because you are the one designing the appliance. So you choose what you want. You choose your first component. You know the mallocation you're seeing. So you decide whether you want to use a spring, a bow, or whatever. Then if you now want to go and choose a spring, there are different types of springs that you can use based on the problem list that you have. And she has rightly said in which instances you want to use which. So the simplest example of the spring is the cantilever spring. I think that was our first example, right? So other types are the Z spring, like you said, the T spring, the coffin spring, the canine retractors, uh, which one again is she saying? Uh, there are also molar springs, single incisor springs, palatal springs. There are different types of spring, but you have to know what indications are for which ones. So as we said, the simplest one is the cantilever, which is what they will bring, even for you to identify. Then you have the double cantilever as well. So you should be able to know all of those ones because in your OSCEs, that is most likely what you will see. Then as you said, the Z spring, the T spring, and the coffin spring, they are very common in the clinic. So you go to the lab and ask them for all of those springs because that's what's most likely going to be coming out, the simple ones. Hmm?
Yes, ma'am.
Good. Then I'm sure you heard mentioning you can guard your spring sometimes. So depending on how you want to use it and where you're using them, you can put them inside guards to be protected. And then the implication or the importance of that formula I gave you, you also need to know because variations in the length of the wire, variations in the diameter of the wire affect the amount of force you can continue to apply continuously on the appliance. So and for removable appliances, actually, the force you use are just usually light forces, very small forces. You're not producing maximum movement. You're just doing simple tipping movement most of the time. So the ideal force you need to produce optimum tooth movement using removable appliance is a light continuous force. Please take note. Did you hear me? Light continuous force. That's the ideal force you need. So when you're designing, you should take, as I said, you take note of the length and diameter of your wire. Diameter is the same thing as your radius because I gave you a formula for a reason. So the length of the wire, the radius of the wire, all of this translate to how much force you can apply. And then when you're designing the appliance again, the length of the wire should be as long as possible as it can be contained within the confines of the oral cavity. So if it's outside the cast, but you design most of business on the cast, if it's outside the cast, you will not be applying as much force. If it's not making contact with the particular tooth that you want, your force action is 0. You understand?
Yes, ma'am.
Good. So as I said, the most simplest one you'll come across is the single cantilever spring. The single cantilever moves just one tooth. Then you have the double cantilever, which will move 2 or more teeth. And she mentioned anterior crossbite. So you have to be very careful because they give you scenarios. They'll give you a clinical scenario. So you have 1 tooth in crossbite and you have 3 teeth in crossbite. Which of the springs will you use? I want that answer. Single tooth in crossbite and 3 teeth in crossbite. Which spring are you choosing?
Single cantilever spring for single tooth. YZ spring for 3.
Who just spoke?
Ibrahim.
All right, that's good. So very good. So you have 1 tooth in crossbite. Your easiest choice is to go with a single cantilever. You have 2 or 3 in crossbite. You use a double cantilever. Then your springs are activated by a maximum of 2 to 3 millimeters. So I've spoken about the length. I've spoken about the radius, right? Then the radius and so radius, diameter, and thickness, they're usually used interchangeably, but you should know that they mean the same thing. So as I said, your springs are activated by 2 to 3 millimeters. Mm? And then the thicker your spring, or the higher the diameter of the spring, this determines whether you need to support the spring, or whether you need to, let me use the word that Esther is, whether you need to guard, the spring. Mm? So if your spring is as hard as 0.5 millimeter strength, like 0.5 millimeter hard stainless steel wire springs are used. If you use that range, you need to guide it or protect it, or it needs to be protected. You cannot just leave it in the mouth. It has to be guarded. Hmm? Are you
Yes, ma'am.
following? All right, good. What else is important? I don't want to spend the whole day. Like, if this topics are, it can take time, but we don't have that much time, and we'll still be taught in class anyway. So I want us to cover as much as we can.
Excuse me, ma'am.
Yeah.
I wanted to confirm the formula for the force applied. Does force applied is directly proportional to deflection times
Mhm.
radius raised to power 4 over length?
Yes, exactly.
Okay, ma'am.
Hope you've gotten that formula, because Professor Kwetu likes asking that particular formula. Hmm? Let me say it again. So force is directly proportional to D meaning your deflection, R meaning your radius, raised to the power of 4, all divided by length. That's L, raised to the power of 3. So as I said, please go to the lab and look for all of these things. Look for the single cantilever, look for the double cantilever, because those are what they will bring in OSCEs. Do you understand? Hmm?
Yes, ma'am.
So let's leave springs alone. Let's move to bows. Rosemary, is Rosemary in class, or she's just present online? Damilola, I've called 2 names now. Bows, Henry, that's the third name. 3 of you don't respond. I won't be signing your book. Nobody's responding. The 3 of them are not responding. Temitope, Muna, no response. Ainde, oh yeah, Bows.
My just Mona and I
Mommy,
had barely
no.
unmuted before you said the
Yeah,
response.
now, let's not, we spent 30 minutes already. Is this not
Mommy, yeah.
an hour tutorial, right?
Yes.
Both, please. Ha. Mama, what's going on? Your classmates don't want to talk again.
My
Let's call
Ma, they
Esther.
are
Sorry,
yeah,
ma.
both.
Let's call Esther to
Ma,
continue
what's
this
it?
tomorrow.
no
It's
ma.
my
I think
network.
they are in the class. It's just that the Saturday is not really.
Mommy,
I'm sorry.
Ma,
not really.
Today is Monday. Oh, today is Monday. It's not Saturday. It's Monday.
ma, who
Who
do you
do you
want to
want
talk,
to
ma?
click on both? You know you can't make
Talk,
people.
talk like an interactive class. Please shine. Bowls, please. Let's go on. Bowls. Can we have someone talk about bowls?
Yes, ma. So, ma, this is Ainde.
Okay, ma.
Okay, Inde, go ahead.
Okay.
So, those are wire components that are placed on the labial side of the teeth, on the labial surface of the teeth. So, they are mainly used to retain, to guide, or to apply forces to the anterior teeth. So, for the type of bows we have labial bow. So, they can be standard or short labial bow. We have long labial bow, split labial bow, reverse labial bow, high labial bow. Then for the standard labial bow, it's usually made from 0.5.
Okay, pause. Let me, before we run away from what is important, because they're going to ask you for your bowls. As she said, they are And people are not talking about hard stainless steel wires, please, because they're soft stainless steel wire. Hard, hard
Okay,
stainless
ma.
steel wire. Hmm? So as
Yes,
you
ma.
said, they are placed on anterior teeth on the labial surface, right? And they have more force. They are more complex than the springs. And you can use them in different ways. You have more uses of the labial bow that you can have with the springs, because you can also incorporate loops and bends or whatever into the bows as you need them. So, and then different strengths of the wire. So you see for springs, I mentioned 0.5 millimeter hard stainless steel wire, right? For the bow, you can have 0.5 millimeter, you can have 0.7 millimeter. And this again is another question for you. MCQ and short answer, even in your OSCE. Because they will give you a Roberts retractor and they will give you a Holly's retainer, or they'll just give you one. And the question on that is like, what strength of wire, of what strength is this? And you answer. So you can tell me.
Sorry, ma. Are you talking about Holly?
Ma, for Robert,
Anybody can answer. So in Robert's retractor and in Holly's retainer, is it the same strength of the hard stainless steel wire?
I think Robert is 0.7
Robert has
and
0.9.
Holly is 0.9. I'm not sure. 0.5. Holly is
Okay, so who
0.9 millimeter. Robert should be 0.7.
and
I'm guessing.
okay, I'm saying it now. Dr. Dai said it's nobody should go and quote me wrongly when I switched it. Hmm? Your Robert is 0.5. Get it now. While your
Okay,
Holly's is
ma.
0.7
Okay, ma.
millimeter
Okay,
hard stainless steel wire.
ma.
Let
Okay,
me
ma.
say it again.
Thank you, ma.
Robert is 0.5 millimeter hard stainless steel wire, while in your Hollies, it is 0.7 millimeter hard stainless steel wire. Then another follow-up question would be, which one is active, which one is passive?
Robert is active while Holly's is passive.
Very good. Share learning.
Yes, ma.
These are the relevant things. Very good.
Yes, ma.
So let me say it again for emphasis. Robert is 0.5 millimeter hard stainless steel wire. And it is an active bow. Hollies is 0.7 millimeter hard stainless steel wire, and it's a passive bow. But then again, depending on our patients and the treatment of how we're ending their treatment, you will hear us most of the time in clinic about giving recurrence, like make the bow in the Hollies active. But on a normal, your bows in the Hollies are passive. But as a clinician that knows what they're doing and knows what they want or know where they are finishing off treatment, I can make a Hollies retainer active. But for all purposes intended now in this class, Robert's bow is active. Your Hollies retainer bow is passive. Clear?
Yes, ma.
Good. Who was teaching us? Or let me continue. Should I continue?
Yes, ma.
Okay. So I don't know who was speaking, but what the person said that labial bows are usually the bows are usually placed labially, anterior teeth, and they are used to retract. I think we got all of that clear. And then there are different types. She was talking about a labial bow being short and a labial bow being active, which is very correct. So depending on how you want to use them, you can have your long bow or your short bow. So the difference between the long and short bow is just basically where you bend in the loop. You know, I said you can bend in loops. You can bend in loops in your labial bow. So that's what makes them the U loops that you have. That's what makes them either short or long, depending on the distance you have from them. Some of the loops are bent just after the canine. Then you can have it being bent again around the premolar area. So that's what's going to make it short or long for you. What other types? So there, I think she mentioned there are split labial bows. So that's when you have the labial bow divided into two labial arms at the incisor area. But when you're splitting that labial bow, you have to be sure that the curve of the bow is not affected. So you have this is just listing. Now nobody's going to ask you all of this. So just for you to know examples. So you have short, long, split labial bow, double labial bow, one again, mule's labial bow. Those are examples. How many do you have up to 4 or 5? Because most of these questions you asked you 5,
Is there
4,
reverse?
3.
Is there reverse labial bow?
Reverse labial bow. Where did you sit down? I don't think I've come out. What I know, the long, short, mule, labial bow, split labial bow, double labial bow, reverse labial bow. Where did you see it?
No, I will just check that. I saw something like reverse labial bow that it has like a U loop placed distally that is for retraction of proclined incisors. So I don't know how true.
So
Like,
maybe that's another name, but these ones that I've mentioned are like the most common names that I know. So I can check,
thank
but I
you.
think I've mentioned the most common ones that go around.
Yes, ma'am.
Okay. So the next component now is screws. Who is talking about screws? Where are my Calabar people? Are they here? I want somebody to talk. Have any of them been talking?
You called Gideon before and you've called
Okay,
Rosemary.
and he answered, right?
Yes, Gideon answered.
Please, amen. Amen, will you talk to us about screws? Please don't waste our time.
Good afternoon, ma. Okay.
Good afternoon.
So screws are orthodontic appliances. They are part of the active components of removable orthodontic appliances, and they are used to apply force by gradual activation. So unlike the springs and bows, they produce controlled and continuous expansion forces. So the types the types of screws, we have the expansion screws. They function to expand the dental arch, and they are usually used in cases of posterior crossbite and when the arches are narrow. We also have the unilateral expansion screws. They are also used when they are used unilaterally on one side, and they function to correct asymmetry of the dental arch. Then we have the surgical screw. They are also active components that are
Okay, okay.
used.
It's okay. Thank you. It's okay. Thank you. Let's take it back to what you guys need. So screws. So you said orthodontic appliance, they're part of your first component. The orthodontic appliance in play here is a removable appliance. Understood? The screw on its own is not an appliance. It's a component of your removable appliance. And for screws, the screws are usually embedded into your base plate. So they're one of those components that are actually embedded into the base plate of the appliance. And then it might be asked to describe what it looks like. So how it looks like is what makes it the different types. So your screw basically consists of a rod with a left hand side and a right hand side thread. And they usually, as I said, they're embedded into the base plate. So they act directly on the teeth through the base plates. And then the screws, they are rigid and they transmit heavy forces, heavy intermittent force. Are we clear? So the force is, I mentioned for which one did I mention? Light continuous force.
A spring.
Good. This one is heavy intermittent force. I know that in all our twist movement, whether you're using removable and whether you're using fixed, also we really do not like heavy forces. It's not the ideal. We prefer using light continuous forces, whatever we're doing, light forces, frictionless force. So the screw delivers heavy intermittent force. And then this screw again is one in which you need the cooperation of your patient, because the patient are the ones that will be activating the screws. So each time you activate the screw, you get about 0.2 millimeter worth of movement. So you can have, depending on type of screw you're using, you can have the screw being activated once a week, you can have it being activated twice a day, you can have it being activated once a day. So another difference again is that the spring, when you compare the spring to the screw, which one do you think is lighter? Which one do you think is bulky? Which one do you think is heavier?
The screw is going to be heavier than the spring.
Very good. And more expensive too. So it's more expensive. So when you see us using, okay, let me talk about which appliance now. Okay, those expansion screws. Example of expansion screw, the screw you use in Hyrax. You've seen the screws in Hyrax, right? That's a screw. Have you seen Hyrax? Nobody's answering. You know what a Hyrax is?
I think I
Is
know
it
what the
that
hair
maxillary
is.
expander?
Exactly. So the main component in that thing is the screw. And it's bulky and it's expensive. I know I described it as a rod that has a right arm and a left arm. So it's, the way you place it also in your base plate, you can place them transversely, you can place it vertical. So the way you place them is also important, because how you place it determines how you're expanding, because you can also use screws to actually contract as well. So how you place the screws matter, and the direction of how you place the screws is how your patient is going to activate it. Because activating the screws, you need to use something called a key. So when you guys are in the clinic, I think I have screws that are not in. I should have a screw somewhere. So there's a screw, there's the key. You should be able to identify those two components. And then the key is what the patient uses to activate the appliance. Or the next time you're in the clinic and there's a Hyrax in any patient's mouth. I have a lot of patients with Hyrax. Our has a lot of patients with Hyrax. You can ask her to just teach you how you slot in. There's a slot in the middle, dead in the middle of the screw, that your key goes into. And then when you look at the screw, there's a direction of movement. There's an arrow that is indicating how you should turn. You know, I've said each turn produces 0.2 millimeters worth of movement. All these are very important. These are the questions they ask. What a quarter turn is, how often you should turn. So depending on your appliance, you have, I said, once a week, once a day, twice a day. Capish?
Yes, ma'am.
Okay.
But sorry, I didn't get that, ma. You said something is turning
Good.
0.2.
I said
I
how
don't
you
get
activate your screws. There's a key. If you keep the screw in the mouth and you're not, and I said your patient is very important in this instance, because the appliance is not going to work on its own. The appliance in this instance needs to be turned. The screw needs to be turned. There's a key. So there's a spot in the center of the screw that key will enter, and then you turn. So we call it a quarter turn. And a quarter turn means that you're introducing 0.2 millimeter watts of movement. It's very small, right? Do you understand?
Yes, ma. Thank you, ma.
Uh-huh. So as I said, the quarter turn is just equal to 0.2 watts of movement. That's what a quarter turn will give you. And then I said, your patients are the ones that do this for you. So if you have a screw in a patient's mouth and you're not seeing any movement, you're not seeing any expansion, it means that your patient is not doing anything at all. It's just wasting your time. And there are ways to actually check. So it doesn't matter what the patient tells you. When you look into the mouth, you will know for sure whether that appliance has been activated or not. So next time you see me or our, and just ask, any of you ask for a patient that has a high reps. And me, I think I personally have screws somewhere, screws that are not in play. So you can look at them and then look at the key. Or you can even go online and check. There are pictures of these things everywhere. So as I said, is a rod with a left arm and a right arm. And the hole is just dead in the middle of those arms. And then how you want to direct your movement is how you place the screw, embed the screw in the base plate. Do you get?
Yes, ma'am.
So the last component is elastics that I said are no longer in play. They are no longer commonly used. Hmm? But when they were commonly used, they were used in place of the bow that we use right now. So they were used as an alternative to the labial bow, either to procline or retrocline the incisors. I think why they stopped using elastics was because they found out that the elastics will not just stay where you place them. The elastics can move into the gingiva. They can cause damage to the teeth. They can slide. They will not remain where you've placed them. In between appointments, they've moved. So over time, it has been reduced. Its use has been reduced as part of the components of removable appliances. And also, you know that elastics have what they call it now. They have these uh, trying to find the right word. Like they do not last over time. Like they diminish. Like the power in the elastics reduces over time, right? So the force is not the same. Someone should remind me of the word I'm trying to find. Mm,
The elastic limits, or
yeah, it deteriorates. Like it deteriorates. Like even when you use models, when the first day you place the models and the day you're sending the patient back, is the models the same force? Is it the same force you think the models have? Is it the same elasticity that they will have? So over time, the elasticity deteriorates. So that is why they are not the force that they apply were not constant. So they were removed. They're not used again as often as the springs, the screws, and the bolts. So that's first component. Can we move on? Because there are other components. So they're like we've not talked about retentive component, anchorage, base plate. Oh, yeah, we're going to hurry now. Retentive component, please. Somebody else from Calabar. How come it's only MM's name? There's somebody else.
Ma, I'm not from Calabar.
MM. MM. Who is speaking? Who are the students that came from Calabar? They not in this class.
Man from Calabar.
Now spoken.
The students from Calabar, they not here.
Man from Calabar.
Who is speaking? Identify yourself.
Deborah Asukoma.
Sorry?
Deborah Asuko.
Who else?
Man from Calabar.
Who
Now
else?
given
Name,
I've
please, name.
spoken already.
I'm
Damilola.
also from
Okay. And so I know your name. Ah. So MM is telling me she's not from Calabar. She's with us in Lutia.
Yes, ma'am. With you, I started
Okay,
from.
sorry, my bad. Okay.
Thank you, ma'am.
Damilola, oh yeah, talk to us about retentive component. So let's move so we can still make use of our day. Yeah? Retentive component, please.
Retentive component.
Please, whoever wants to speak can speak. Anybody.
Now for the retentive component,
Yeah, go ahead. Yeah,
um,
Deborah. Mm-hmm.
we have the claps.
Mm-mm. No. So you're going to define what it does
Oh,
in
okay,
the
okay, okay, okay.
appliance before you give me examples.
Okay, so a retentive component, they are parts of a removable appliance that holds the appliance securely in the mouth and prevents displacement during function.
Okay, very good. So let me come in here. So the primary aim of retention, the primary aim of a retentive component, its primary use in your appliance is to resist displacement. And sometimes they form part of your anchorage. So they resist displacement and can form part of your anchorage. So now the types, examples.
We have the Adams clamps, the C clamps, also known as the circumferential clamps, the ball end clamps, and the south end clamps. For the Adams clamps, it's the most commonly used, and it's usually used on the first molars. Then for the circumferential clamps, it basically encircles the tooth and it engages into the gingival undercut, and it's commonly used for the premolars or the anterior teeth. Then for the ball end clamps, um, it's shaped, the end of the wire is shaped like a ball, it's shaped into a ball. So it engages into the undercut and it's not sharp, so it's more comfortable for the patient. Then for the south end clasps, it has a rounded end, and it's often used for the anterior teeth. And it can also act as a retentive or active component from what I saw.
Everything she said is correct. The only thing she did not add that I'm going to add is the dimension of the wire, usually 0.7 millimeter. And as she said, Adams clasp is the most commonly used, and is usually used in the molar region. So as I said, what did I say dimension is 0.7 millimeters.
Yes, ma'am.
Good. You can ask Mr. Tony in the lab to show you. Even you can be there when he's bending it. Because even for postgraduate level, I bent an Adams clasp in an exam. So there are skills that are good to have. Let me give the examples that she gave in, because those are also when they ask you list types 4 or 5, those are the types. You list the Adams, the south-ended clasps, the ball-ended clasps, and then the C clasp. Those are your common examples. So let's move on to anchorage. Who hasn't said anything at all? Adeshina.
Now we have three additionals.
I don't know. The one that have not said anything. Both of them have not said anything. Which one? Oh yeah, whoever has not said anything should just talk about anchorage. Nobody wants to talk about anchorage. Sharon. Okay, anchorage simply definition is resistance to unwanted tooth movement, right? That's your simple definition of anchorage. So it's that component or the removable appliances that resist unwanted tooth movement. Your type of anchorage, I don't know if I've spoken about this in the clinic. The simplest classification, because there are different ways you can classify anchorage. So the simplest that you should know for now is just we have simple anchorage, reciprocal anchorage, reinforced anchorage, extraoral anchorage in the forms of uh no, which one is TADS? Where do you put TADS as, because TAD is an anchorage device. So under what example? Nobody's talking. You guys don't know anything about anchorage.
Ma is a skeletal anchorage.
Very good. So what's your example of an extraoral anchorage?
Headgear.
Very nice. Good. So the head cap in your headgear, the ones that have neck strap, those are the form of extraoral anchorage. So as I said, the simplest, there are different classifications of anchorage, but the simplest ones, if they ask you, sharp, simple anchorage. And when you're saying simple anchorage, you just mean that you're using the teeth. There's a teeth of greater anchorage, of the greater resistance, sorry, is what you're using as your anchorage. So is it teeth in the mouth. When you have reciprocal anchorage, it means that you're putting two groups against each other. So two teeth of equal resistance, of equal strength is what you're using. That's reciprocal. So you can do them in opposite directions. What example for reciprocal anchorage would that be? Which one is the most common example for reciprocal anchorage?
Ma, I'm not sure. Is it closure or a midline diastema?
And so when you're doing transverse arch expansion, mm, when you're using an expansion plate with your midline screws, that's reciprocal anchorage because you're expanding in both sides. Do you understand? So it's reciprocal. You're using the teeth from the right side against the teeth from the left side, and you're splitting your screw is dead in the middle, so you're applying the force in both directions. Hmm? So you're trying to either trying to move them away from the midline or you're moving it towards the midline. Do you understand? So that's reciprocal. Then reinforced. Example of reinforced anchorage is when you're using like a transpalatal arch, TPA. And so you see that loop in the arch, that's what's giving you the reinforcement that you need. Mhm. So anchorage is a whole lecture on its own. It's wide, which is why I said there are many classifications, but pick these 5 ones that I've said: simple, reinforced, um, reciprocal, extraoral, and then skeletal or anchorage, where you have the use of cards. So I said, and TPA, you know what TPA means? Transpalatal arch. Non plans to their examples of reinforced anchorage. So let's move to your base plate. Okay, who's talking about base plate? I said this is an interactive session. If you are making me talk more than I thought I would talk.
Ma,
Mm-hmm.
the base plate is the acrylic foundation of the removable orthodontic appliance in which the screws, springs, and clasp are embedded. It provides support, anchorage, and stability for the appliances.
Very good. Who can say something else before I just refashion what he said? But let me go ahead. So your base plate is like the connector of all these other components. It's what holds all the other components together, and it's made of acrylic. It also determines the fit of the appliance for the patient, which is why you can't use one appliance for different patients. You always have to take your impressions and then make appliance per patient. So it determines your fit, it holds all the appliances together. Then it has a lot of function actually. It does provide the I said connection, major connector. If you do what they call it now, Prostec. I think that's where they use that word. But it does provide the connective framework for your springs, for your bows, for your clamps, everything is the connector. Then it provides retention as well. It provides anchorage as well because it keeps everything in place, right? It keeps everything in place within the framework of the mount. Then it also provides the framework by which your force can be equally distributed across all the components, across all the areas in the mount. And then again, another thing that your base plate can be used to look at. Your base plate, you can refashion your base plate to form bite planes if you want to. Then your base plate, when we talk about boxing in your spring or guarding your spring. So when you look at some of the devices, you will see how the springs were protected or boxed in within the base plates. So that's the function of your base. That's what your base plate does, all in all. So now let's move on to indications. Well, I want 10 indications. 10. The most they will ask you in your short answer questions is 5. Give me 10. Let's start rattling. I don't want to call names at this point. Let's just rattle them. Thank you.
Ma, for retention, the corrected of the correction has been done.
Okay, nice attempt, Muna. Anybody else?
Arch expansion.
Ma, for space maintenance.
Very good. So let me list it for you. Right to jot. I'm going to try and list 10. The most they will ask you is 5. Please pick the best 5, the easiest 5 that you know. So in the beginning, what did we say that the removable appliance is meant to do?
Simple tipping movements.
That's your number one. That's your number one indication. Before you start talking about any other thing. What again from the beginning that did we talk about? What did we talk when we talked about active and passive? What did we bring out of those when we talked about it?
Correction of anterior crossbite.
We talked about space maintainer, we talked about retainer. Are you seeing how I'm bringing about my indication? So first indication, simple tipping movement can be used as space maintainers, can be used as retainers, can be used as habit breakers, can be used for correction of crossbite, for elimination of occlusal interferences, for minor derotations of anterior teeth, for simple extrusions and derotations. How many have I listed now?
Ma, you lost us, ma.
I love you. Find yourself. So indications for um, removable appliances, simple tipping movement, right? Correction of anterior crossbite. I said space maintainers as retainers, as well for habit breaking, for minor derotations of anterior teeth, for simple extrusions and derotations, and then for elimination of occlusal interferences. Pick your best 5, simplest ones that I can remember. Also for overbite reduction. We still up to 10, right?
8.
Only, really. Anyways, you need 5.
Ma,
Mm-hmm.
I wanted to ask, an embrasure hook, is it a spring or a retainer?
Embrasure hook. The only time I mentioned embrasure And somebody mentioned embrasure is when you were talking about the ball-ended flaps that can be used in embration surfaces, embration areas. Am I correct? So what do you mean by an embrasure hook?
No, it's a type of this. I know it's a type of this thing that is part of the what you call it, all this retainer, the Adams class, labia bow, Adams class embrasure hook. So I
Okay.
wanted to confirm if the function of the embrasure hook in that appliance in the always retainer specifically.
Okay, wait, hold on. So your police retainer, describe the components for me.
The labia bow
Mm-hmm.
for then Adams class for retention,
Mm-hmm.
the base plate, like the base plate that holds the whole everything together,
Mm-hmm.
and embrasure hook.
Embrasure hooks. I need class. You guys have notes. I think there's a picture of a Holly's retainer. So I want us to be very clear. Because again, there's another question I just remembered that popped into my head when they ask you differences between the Hollies and the Roberts retractor. There's another classical thing that is different for both, and it's in the base plates. Mama, can you Google the picture of a Hollies and find? Let me see if I
Ma, is
can
it a
find
collet?
a patient's Hollies and bring it out.
Ma, is it a collet?
Okay, I just saw it.
Exactly. Exactly. Very good. So that's the one. That's what I'm talking about. So the Roberts retractor. I want to know who spoke about these embrasure hooks as being part of a retainer. I
Abdullah, my
want
brain.
Ibrahim. Good. I want your picture of the Hollies and what you're calling an embrasure hook. Then who talked about collet right now?
Ma, Ntwe Samuel.
Huh?
Ntwe Samuel. Samuel.
Samuel, very good. So that's the major thing. Apart from the strength of the labial bone. So that's the second major thing. That's the second thing you we use to identify which one is Roberts and which one is Holly. So sorry, you said Samuel, right? So which one has a collet?
Ma, I think Robert has a collet. I'm
Are
not
we
sure.
sure? So who is bringing up the picture for me of the Holly's retainer? Let me see. I'm coming. Let me find my own pictures. So you learn this now because that's also a question I've seen when they ask you to do a spot diagnosis and the major difference between, or they say list two differences or three differences between the Hollies and the Robert. Samuel, you know what the collet is, right?
Yes, ma. They are like,
Oh,
they
can you
engage
try and
into
describe the
the
collet are like all those like
fingers
you that form
projections.
around
Too.
the tip, right?
Yes, ma.
So that's the collet. So that's present in your Hollies, but it's absent in a Robert retractor. So if you can draw up pictures, and whoever it is, please share it on the group so that everybody sees it and it's clear. Then the person that said embrasure hooks, I want to know what you're calling embrasure hooks, because that's not necessarily how we um describe our Hollies. There's a way you describe all of these things. Mama, is anybody doing it, or you are going to do it on your own? Can you guys hear me?
Yes, ma'am. I'm trying to get a picture of the embrasure hook, but what I'm seeing is different from what I know as embrasure hook.
Good. So let's do it. Samuel, right? So please find me when you see me in the clinic. Uh, we're always making appliances every day, if not even in the lab. So let's get our own appliance because that's what they'll give. Those pictures of our appliances that they will give. Mhm. Well, I want to find the picture. Okay, Mama, again, before the end of the day, remind me. I have my pictures, my patient's pictures. I will find a picture of Hollies and send it to Mama. And then he can share it to you. Then the
Okay,
person
ma.
that shared the embryo hook, so you now like just put a circle on the picture I will send to Mama and tell me what you're calling embryo hook.
Okay,
Then
ma. I think I found a picture of something like the embryo hook. If you don't mind me sharing my screen.
yeah, let's see.
Okay, can you see my screen, please? So it actually looks something like this, but just for a clearer picture, I think this should be a clearer picture. Sorry. It looks like this basically. But then it's not like we do like two parts like this. It's just
So
one
so now,
one side.
looking at what is on the screen showing now. What part of this do you guys see in our Hollies that we fabricate?
Like it's just this like maybe section, like just one part of these four sides that look like that is like the embryo hook we did. That was in year 4.
Uh-uh. So
So
now, the
it
question
wasn't
I'm
this look.
asking now, in our normal fabricated Hollies, what parts of what looks like any of these that is on the screen currently in the fabrication of the Hollies?
No, no, ma.
Exactly, because simply the simple components of a Hollies, are your labial bow, your Adam's clasps. That's all. Is there any other thing inside the Hollies? Eh?
Okay, ma.
No, now, no, there are things that might be happening elsewhere that we don't know. But I'm just saying, like, what happens in your clinic, in your environment. So when you're describing like the components of the Hollies, what makes up the Hollies, I will not be hearing that embryo. That's why it threw me off. Hmm? Embryo hook inside your Hollies. From where? You get? Was it Ibrahim or Samuel again? I'm mixing your names. So Ibrahim, right, was the person with embryo hook, right?
Yes, ma.
Good. So where you saw it, please, I'm interested. I want to see. I want to see how they call it an embryo hook and what makes them call it an embryo hook. Then I said I will send my own picture of my patient's Hollies, and then people can also go to the lab and look at Hollies. And then even in your notes on retainers, there's standard descriptions of what makes each of the retainers. Like they will tell you the strength of the wire and everything, the components, and the way we're taking removable appliances right now. For each of the retainers, that's the description, the lab, how you make it in the lab, how you fabricate in the lab, the instructions you give to your patients, and all of that. So you don't come across that embryo hook in Hollies. Hmm? So, Mama, please remind me that I should send a picture of a Hollies, like Lutz fabricated Holly. Okay. Then Ibrahim, please. I need to know. I want to see it. Hmm?
Okay, ma.
All right. Then Samuel will clear your collets, right? The collets, the difference between your Roberts and
Yes, ma. The color is in the hall is not Robert.
very good. And I'm not joking, this is a question. I don't know whether they are changing your questions, but this like difference or the spot question, they'll put in the Hollies or put in the Roberts and say identify. Then the follow up is differences between this and the Hollies, or in what areas or in what small locations can you use this, or what do you use each for? Hmm? Okay. So we're done with indications. What's next? How did I use this? How we're going to discuss all of this. After indications, I said what? Instructions for use, right? Are we still together?
Yes, ma.
What instructions do you give your patients? So because I've been hearing and seeing many funny things. Currently, I hear that patients eat with their appliances, they keep their appliances in their mouth when they're eating, and that is not how it used to be before, but I don't know what is going on now. Maybe I'm old school. Oh yeah, instructions, please.
You advise them not to eat sticky or
Hmm?
Like they should wear it except when they are eating or when they are
yes,
cleaning.
the appliance.
I know that is what we say, but current practice, like what actually does happen? Because I ask my patients and they will tell me it's in their mouth all the time that they are eating with it, they are chewing with it, they're doing everything with it. And why do we, there's a reason also why you don't want, apart from breaking, I think there's another reason. There's something that happens with your base plate, right? When it's exposed to extremes of temperature. Am I correct? Am I?
I don't know, ma.
Yes, ma.
Yes,
Mm.
Maya, correct.
Yes, ma.
I'm correct, right? Is that something that happens with hot water or
Yes.
there's something, right?
Yes, ma.
Okay, good. So your instructions. So for the first 48 hours, as much as possible, they should keep it within their mouth almost all the time. The first 48 hours are very critical. So when an appliance, whatever the appliance is introduced in the mouth, the first thing is discomfort, and then there's a lot of salivation, and your patients will tell you, "Ma, I can't talk properly, or I can't speak properly. I have a lot of saliva in my mouth." Is this normal?
Yes, ma.
It is normal. It's expected. But then your instructions will be like, yeah, yes, within the next 48 hours, we experience some discomfort. It's very normal. Your speech might be affected. And then you try and encourage the patient, but I can hear you clearly. Then you ask the patient's mom or the dad, can you hear him? Can you hear her? So you tell them that you can hear them. They're not wrong saying that they feel like they speak wrong or they're speaking funny. It's okay. But in the next 48 hours, that difference will not be there. And even as they're speaking to you, it's quite clear. It's just that it's a bit different. So speech should be affected. And then they will salivate a lot. And they're salivating a lot because a new foreign body has introduced in their mouth, and that will stop in the next 48 hours. But they must wear their appliance religiously over 48 hours. Then they're not supposed to eat with the appliance in their mouth.
Good
But
afternoon,
that,
ma'am.
yes,
Yes, ma'am. I wanted to also remind you that we have an in-course on Wednesday morning. Just
why are you
for it.
reminding me? So I should let you guys go, Abby.
No, ma'am. I just wanted to just inform you.
Mama, have we gone over the stated time we're supposed to spend? Where's Mama?
Ma, we have.
It was just for 1 hour, right? Okay, let me rush through the end. So your instructions, wear the appliance all the time. Some people say including at meal time. Some said not at meal times. Now I don't know at which where I am in this really. Then I've talked about the discomfort. You should tell them about the discomfort they have to face and that to pass in the next 48 hours. And then they have to keep their teeth and the appliance perfectly clean. So while they're brushing their teeth twice a day, they should also clean their appliance by they should get a soft toothbrush, different toothbrush to clean their appliance and then rinse in tap temperature water. That's tepid water, right? Then they are not to eat hard and sticky substances with the appliance as they can damage the appliance, which is why for me, I just feel like you should not eat with the appliance. Hmm? Then in case of any damage to the appliance, you should return to the clinic immediately because if you stop using the appliance for 2 weeks, it means that for 2 weeks to 1 month, you've not done anything. So if it's broken, come back as quick as possible. Advantages of removable appliances. As I said, you don't need a specialist, you don't need an orthodontist to use a removable appliance. I expect that you as dental officer, when you're posted somewhere for your NYC, you can fabricate a removable appliance and be confident enough to have your patients use them. So they are inexpensive, and then they're for simple forces, so they're not used for very excessive force. And it requires little chairside time. It can also be removed in environments where the patient is feeling self-conscious and all of that. So you can remove the appliance at any time. So that's an advantage. That's why it's called a removable appliance. And then it does not hinder any other form of treatment that the patient is going to be uh, having. So the disadvantage based again off with the fact that it can only provide simple sweeping movement. So you can't really do much with the removable appliance. So you can, it's limited. The use of the removable appliance is limited from the get-go. Then you need your patients to cooperate with you. You need their compliance for the appliances to work. I've said it's simple tooth movement, so you cannot do multiple tooth movements with your removable appliances. And most of the time, the appliances are just for the upper arch. You hardly use removable appliances in the lower arch. And then you always need to have a lab available to fabricate your appliances. So that's all for removable appliances. We're done. So, Mama, you can find another time for the base plates, and then I'm done with the tutorial.
Master, I have a question, ma.
Yeah.
Ma, okay, for the movable appliance, can it be used at night, like to sleep?
Yes. Depends for 8 hours. We tell them to wear it all the time, day and night. So you can actually wear it at night. You don't take it out. It's worn all the time. Does that answer your question?
Yes, ma. Thank you, ma.
All right, you guys should enjoy yourself. All the best. What's in course do you have on Wednesday?
Prostodontic.
All the best.
Amen. Thank you so
Thank
much,
you,
ma.
Ma.
All right. Bye.
Bye, Ma.